Welcome back, everyone. Today on Health Code Blueprint, we're diving into mastering Neoplasm coding, a guide to accuracy, compliance, and risk mitigation. This session will help you strengthen your coding accuracy, avoid common pitfalls, and understand the documentation elements that drive compliant Neoplasm coding. Before we begin, here's a quick disclosure. This presentation is for educational purposes only. It does not constitute legal, compliance, or billing advice. Always follow official ICD 10cm guidelines, organizational policies, and regulatory requirements. Let's start with why precision matters. Cancer is the second leading cause of death in the United States, responsible for 1 out of every 5 deaths. Because of this, accurate Neoplasm coding plays a major role in patient care, population health data, and risk adjustment. From a compliance standpoint, OIG audits consistently show that incorrect Neoplasm coding is a major source of non-compliance in Medicare Advantage. Common errors include coding cancer as active when there's no treatment within 6 months, when the cancer is actually a history of, or when documentation doesn't support the diagnosis at all. Here's our roadmap for today. We'll start with the foundations, the language of neoplasms. Then we'll look at classification, behavior, morphology, and types. Next, we'll walk through the ICD 10cm rulebook for Neoplasm coding. And finally, we'll apply everything to real-world scenarios and highlight compliance pitfalls to avoid. A neoplasm is an abnormal mass of tissue caused by uncontrolled cell growth. To code neoplasms accurately, you need to understand 2 key concepts: behavior and morphology. Behavior describes how the tumor acts, whether it's malignant, benign, in situ, or uncertain. Morphology describes the cell type and structure, such as carcinoma or sarcoma, and helps guide you to the correct code. Neoplasms fall along a spectrum of behavior. Malignant tumors invade and spread. Carcinoma in situ represents malignant changes that haven't spread beyond their original location. Benign tumors don't spread but may grow large enough to cause pressure effects. Uncertain behavior means the provider cannot determine whether the tumor is benign or malignant. And unspecified behavior means the documentation doesn't specify behavior at all. Understanding behavior is essential because it determines the correct coding column. Malignancies behave differently depending on where they originate. Solid tumors begin in a specific organ and spread through direct extension or metastasis. Hematopoietic and lymphatic cancers originate in blood-forming or lymphatic tissues and may appear in multiple sites at once. This distinction is critical when determining primary versus secondary coding. One of the most important rules in Neoplasm coding is distinguishing primary, secondary, and history. Metastatic from identifies the primary site. Metastatic to identifies the secondary site. A personal history code from category Z85 is used only when the primary cancer has been eradicated, there is no active treatment, and there is no evidence of disease at that site. If any of these conditions are not met, the cancer is still considered active. Next, let's talk about location. When a tumor overlaps 2 or more contiguous sites, use the 8 overlapping lesion code. But when there are multiple tumors in the same organ that are not contiguous, assign a separate code for each specific location. This ensures you accurately capture the extent of the disease. There are 2 special cases coders must master. First, lymphoid cancers that spread to solid organs are coded using the lymphoma category with the extranodal extension character, not as secondary neoplasms. Second, unspecified malignancy codes like C80.0 and C80.1 should be used sparingly and only when documentation truly lacks detail. The OIG frequently invalidates neoplasm HCCs for reasons such as no treatment within 6 months, documentation supporting history, not active disease, insufficient documentation, incorrect severity level, missing medical records. Your coding must always reflect the documentation, never assumptions. Before assigning a neoplasm code, confirm 4 key elements. First, behavior. Second, morphology. Third, anatomic site. Fourth, laterality. These 4 pillars ensure specificity and compliance. Code as current malignancy when the patient is receiving active treatment, under active surveillance, has refused treatment, or is in remission. Use personal history codes only when the cancer has been eradicated and is no longer active. Let's apply these rules. Metastatic carcinoma to the right ovary from the stomach. The stomach is the active primary site. The ovary is the secondary site. Codes: C16.9 and C79.61. Now the documentation changes. Metastatic carcinoma to the right ovary from previous stomach carcinoma removed. The stomach cancer is no longer active, it becomes a history of. The ovary remains the active secondary site. Codes C79.61 and Z85.028. 3 key reminders. Documentation is your source of truth. Master the nuances between active versus history and primary versus secondary. And remember, precision protects you, your organization, and your patients. For continued learning, explore resources from the National Cancer Institute, CDC, OIG, SEER Training, and Coding Clinic Advisor. Thank you for joining me today. And as always, I'll see you in the next video.